Next slide. Okay, good morning, afternoon, and evening, everybody. So this is the outline of the today presentation. Next slide. Thank you. So the project is, as Edgar mentioned, we conducted the studies as a large-scale study. Basically, the idea of the project is that we would like to know, is there the determine, to determine, is there any differences in the access to the public health services between the ethnic minority states and then the non-ethnic minority states, on the other hand, as a Burma-dominated area. So we conducted studies in the Kachin, Chin, and the Kayin as the ethnic group, and the Magwe as the control area, which is the center of the Myanmar with the Burma dominant area. The primary findings and then the subsequent findings reflect that based on the surveys of the 2,800 households with the 50 focus group discussion with the communities. And also we made the interviews with the service provider, healthcare service provider across the states and region, as well as the ethnic health organization from the Kayin. Next slide. So what we found is that before further going to the service provider and the community perspective on the healthcare, general background information is reflected in this table. Here we look at the percent in terms of the formal school attendees and their incomes and the communities are health-seeking behaviors, whether they go to the government or they will go to the mixed health services or the private health services. And we also look at the infant mortality rate because it is the good indicator to know the status of the maternal and the child health situation, status in that situation. Here, the table show the Chin State becomes the area with the lowest formal school attendance with the 65%, and the most poor population state because of the 62% have the income or less than $70 per month. However, interesting point is that Chin State became the area with the highest government health service utilization rate with the 89%, followed by the Kayin and then the Kachin and the Magwe. So the point is also suggesting which I will explain in the later slide. Why we are talking about that this area has the use or the rely on the government health services. Is it because of the quality or accessibility, or maybe don't they have no other option like the Central Plain area? And now when we look at the infant mortality rate, again, Chin State had the highest infant mortality rate compared to the other areas. Next slide, please. Community perceived health service equality was also assessed, and we look in terms of the ethnicity and the Burma in this slide. Among the 2,747 population, Burma constitute average of the 30%, and the rest we combine as the ethnic group as well as the mixed ethnic group, which is combination of the Burma and the other ethnic groups. Here we look at the, ask the question like, hey, do you feel you receive the equal treatment regardless of the religion or regardless of the language? And then we also look at the health staff. Okay, when you go to the health service, do you have the health staff? Do you see the health staff who are same as your ethnic group? And then we also look at the woman and the pregnant woman receive expected healthcare need or not. The obvious information you will find here is except from the religion. Here you can see not much difference between ethnic or the Burma with the 65%. There's some difference with the Burma is the higher proportion like 67 and 82 in language, 29 and 60, and then the 27 and 37 in the healthcare needs, and then the 8% difference between the pregnant woman. That table suggests the information that though there are either whether you are the ethnic group or the Burma, there may be some person who might feel that we don't have no discrimination or that we receive the equal quality. However, Burma seems to have a higher positive view on the whatever they receive, and apparently they are hashtag who speak the same language in the Burma population. Almost it is more than double, 29 and 61. And then another situation suggests from the death table is that though there's some variations, like in the woman who said they meet the expected healthcare need, the pregnant woman who have the receive the expected healthcare needs is that difference is a little bit narrow. So that might be the one of the effort from the international community and then the ministry to the Chin or the Adna ethnic area in these years because of the maybe the 3MDT or the access to health and so on and so forth. So a further investigation might be needed to see the impact level. Next slide, please. And we also look at the community access to the healthcare. After we are talking about the perceived equality, we assess of the improvement of the health service in the 5 years. In generally, around 88% said that okay, they have feel like that there's a health service is improved in the first 5 years, and then no difference significant regional variation was found. However, in further information, investigation, and the interview, there's a reported issue of the affordability, accessibility, and the quality. Affordability is in terms of the transport and the cost of the sustaining oneself and the family in the hospital. So what does it mean? So basically, when I talk about the accessibility in terms of the affordability and the quality, all are might be the standalone or the interrelated, because sometimes affordability means the in addition to the healthcare cost, out-of-pocket payment, one need to spend money on the travel and transport costs, especially when the health service facility like the tertiary healthcare is not situated in their area. It's in the survey and the interview, it came as the highest, thanks, highest risk on it. So the remote area have the problem reaching the tertiary service as mentioned. And then what they said is that wide access is mainly to the very basic healthcare. It means that say is in the rural and the remote area, they access to the rural healthcare service area, rural health center. But however, it is a problem when they have the more complicated and the emergent health situation and the life-threatening situation. They don't have any choice. Because of the not just the remote area, they are already the poor rest of the poor population. And another one key factor barriers came out is that the skilled health staff and the functioning hospital. Almost every of the interviews respondents said that they have the problem. Even there's a hospital, there's a barrier of the having the enough medicine and the supply, and that they have to spend all the outward or pocket money. So these out-of-pocket monies come from the borrowing of the with the high interest rates or the either selling of the agriculture farm or their livestock. So that's a really challenging for them. So another thing is a regional variation. While talking about that, there are challenges. Chin State has shown the highest child mortality rate, lowest health coverage, and the worst access for the health information. However, interesting point is that they have the good impression on the government health services when they get the high score on they are happy about the quality. On the other hand, Kachin and the Kayin show the variation in the pattern in the issues of the transportation costs and the access to health services. Why Kayin show the highest in the first facility barrier? So let me elaborate about more about it, because if you look because the health facility, if you look at the health facility situation in the whole Myanmar amongst 4 states and region, only the Yangon, I mean, the major area like the Yangon or the Naypyidaw, those who don't know detailed information, the major region have the tertiary hospital. Among our 4 studies area, only Kachin has the tertiary hospital. So that might be the issues of that they are showing off the facility barrier. And when we look at the Burma and the non-ethnic group situation, like the 2 groups, Burma showed the higher score on the accessibility, affordability, and a positive view of the health service compared to ethnic group, mostly because of the service they received. Next slide, please. We also look at the gender and the community because the understanding of the gender is very important, and the gender mainstreaming in the health program is essential to reach toward the impact level. So we look in terms of the gender decision making. In addition to the general decision making, the interesting point is the gender difference is found and exists in the family planning decision. Actually, women should be those who should have the decision-making power on their own body. However, men seems to have the main person who decide for the family planning in the household. And then the Magwe, with Burma dominant area, seems to have the more male dominant pattern compared to the ethnic area. We also look at the accessibility of the easy access to the support service for the case of the gender-based violence. Here, Burma groups, it's those who said that they have the easy access, but the lower proportion of the Burma groups than ethnic group with 38 and the 44%. Next slide, please. We look at the service provider. So we conducted the interview with the service providers across the 4 states and region, as well as the ethnic health organization from the Cayenne. So what we found is about any service differences between the Burma or the ethnic or the variation. For them is because of being the health service provision, they provide the equal treatment regardless of the race or the ethnic or the gender or the everything. But however, one significant point we found and that they mentioned is that they can only cover the government control area. And that there's challenge in the remote area, and then the problem to the access to the conflict area. They confront the additional problem with the service provision. Say example in Chin. Chin is the area with the problem with the remoteness and the mostly hilly region and the geographic balance and the language barriers. Why for Kachin? Kachin is the northern part of the Myanmar. They have the still the conflict area on and off. Even when our data collection time, there's a conflict happening, and we have to replace some data collection area. So there's a limit to the provision of the healthcare in the loss region, especially in the gray and the conflict area. On the other hand, for Kachin, comparatively, Kachin seems to be better than the Kachin because of the less conflict. Might be because they have the ceasefire agreement with the compared to the other area. And then there's better coordination with the ethnic health organization and then the government health services. Next slide, please. Talking about we talk at the explore and the brace more about the decentralization. So the decentralization, what happened is that for the healthcare provider, they are always used to the centrally and the top-down centralized administrative structure. So for them is that they are generally happy. They said that they are overall more decentralization and the autonomy since the 2012, and the conditions are more and more improving, and then have the more opportunity now. And that they say the communication is definitely better between the central government and the state and regional service provider. They can communicate directly in case of the situation based on the project nature. However, they mentioned there's a problem in the governance and the decentralization, and then they still require the central government approval. On the other hand, some improvement is also mentioned because we received a mixed response. Improvement in the decentralized decision making in the healthcare supply, including the health staff, facility, and the purchase of the medicine and supplies and budget. There are some of the barriers I will discuss further later. So they mainly say is that, okay, there is a better situation and the more autonomy. However, all the financing is from the central region and the central government. So even they, whatever they requested to approve, there's a time gap in case of the emergency, or sometimes they are the local people who know the who know their community contacts and the community needs. That's the information what we found. So in generally, there's a vast gaps between the expectation as against the provision. Next slide. Again, we look at the gender and the service provider perspective. we found is that gender is not well incorporated in the health service delivery design. The service providers, they have the better awareness of their gender because they receive the different kinds of training, depend on the service provider, duty station, or their duty. However, they do not have the idea on the gender mainstreaming. Because what the understanding of the gender is that they service for the woman health, maternal and child health, or the sexual and reproductive health. And then the service against the gender-based violence exists, but still mainly as a healthcare services in terms of the prevention, either HIV or the family planning, and so on and so forth. And that they are not comprehensive, and on other words, they are not services like the integrated and the comprehensive services coordinating with the various line of healthcare ministry. Say, example, there might be lack of limited accessible for the psychosocial support, social support, as well as all the also the judiciary and the police. And there's some better allocation for the gender-based violence. However, there's no special health service for victims at state and regional level as I reported. And then another factor is according to the provider, health service the same regardless of gender or ethnicity, while community mainly complain of the resource barrier. This is the summary of the information mentioned. So finally, recommendation. The general recommendation of this, while they are welcoming and then they're happy and they're excited about the decentralization, they said they need more human resources in the region. The human resources and the staffing and the budget are the main barrier and the other attention needed for the future decentralization. Because they said that they need for the more autonomous power for the decentralization. Say, example, human resource, especially it's that can titrate with the community research, especially health service, specialist staff, aligned health staff, and then the other budget for the use of the utilization of the purchases. However, they have the concern about the barrier or the challenges because everything is first time. If decentralized, if there is a question of the regional inequality in the budget, someone asks me, okay, where the money we will get? And then, different area have the different resources, natural resources. How about the area with the no resources at all? How about the equality? And there is a point on the agree to have the central government set of the technical guideline, being the healthcare national guideline and the treatment guideline and SOP standard operation procedure should be the centrally standard, and then it should be implemented equally. And then finally, the best modality, what we said and they all agree, is the coordinated mechanism between the national and sub-national government for the technical question, while local government should have the more autonomy for the human resource, infrastructure, service delivery, and the budget, so on and so forth. So yeah, that's the end of my presentation. Thank you very much. So floor is to Jack.
Yes, thank you very much, Miet. And that's the group when they visited Ottawa last October to make a presentation at DRC. We already have some comments on the chat that I think will be worth bearing in mind for the question period. One relates to the limited number of skilled health staff represents a major constraint in the response to COVID in Myanmar. And the second comment or thought is that the appreciation of not having a third tier of Myanmar, only the central versus the state. But as you just mentioned, there's a lot to work on the coordination between the two. So we may get back to these two comments. But we are going to give the floor to Professor Jacques Bertrand. He's the Director for Collaborative Master's Specialization in Contemporary East and Southeast Asian Studies and Professor of Political Science at the University of Toronto. Jack, the floor is yours.
Okay, thank you very much, Edgar. And good morning, good evening, everyone. Just wanted to make very brief comments, given that my position here is that we are actually part of the same project. So I wanted to mainly from a not an external perspective or from an internal perspective, stress a couple of points that I see are worth reflecting on or discussing further. And particularly given that our project is come into this question at a broadly comparative level. Edgar already mentioned we were trying to tease out some areas of interesting discussion regarding decentralization or forms of decentralization in different issue areas, and really are taking a bit of a bird's eye view at this point, an initial cut into some of these very complex issues. So we realize, of course, that health is a very complex area of management and one that one needs to carefully be thinking about on what aspects and how decentralization may or may not improve some of the services received. So I think one of the points that was stressed rightly by in the presentation is that there is a concern about maintaining and improving service standards of care and administrative issues that come with it, such as licensing, training, that are crucial in maintaining a well-functioning healthcare system, and that appropriately are seen in some ways as a sort of national consideration. But there are complexities, of course, that are unique to the healthcare system when we are thinking about decentralization, that come with the fact that there are these different providers. Some are public, some are private, in that really makes the aspects of how to manage the healthcare system quite difficult and complex, depending on, of course, where the availability of private services might actually be available or not available in certain areas. And to just make it even worse, of course, is the fact that you have ethnic health organizations, certainly in Karen State or Cayenne State. That is an important issue of how to integrate what are some pretty well-functioning areas of health management in remote areas of Karen State that require some thinking about how better to integrate. And these are going to be part of important discussions that will happen as the peace process and the political dialogue continues with ethnic armed groups. So, but the presentation has shown, I think in our project, has shown that there are some really important points of tension that require rethinking about certain management aspects. And clearly what comes out are the regional inequalities between ethnic minority states and Bamar majority states with respect to availability of certain services. Yeah, mentioned the affordability, accessibility issues that are actually quite variable from one region to the next. And of course, there are loads of bottlenecks in terms of procuring supplies, decision-making, lags in terms of obtaining supplies because of budgetary issues, highly centralized budgetary processes. So our initial cut into this certainly does suggest that there are areas that need further reflection in terms of decentralization, and including to be better able to respond to sensitivity and gender in particular areas. However, of course, we're quite aware that there is, and responding to one of the comments in the chat, that there really, when we're talking, we're throwing out decentralization here, sort of a general concept, but it really, what requires further reflection is really zoning in on what areas are more appropriately could be thought of as being truly under the jurisdiction of the state regional level, rather than the central government level. And that's certainly something that has come up in education, security, and many other areas, and are crucial to discussions that are occurring between ethnic armed groups and the central government. But health is clearly going to be a very complex issue if those discussions occur, in part because jurisdictional issues will certainly require that fiscal considerations be taken into account, and that's the biggest worry that has come up among service providers when they're thinking about having the state or regional level having more control over some of the decision making. Nevertheless, it's very clear that sensitivity to differences from one region to the next is very important. It might well be that in health, it's better to decentralize along line ministries. There certainly have been some of that occurring already at a minimal level, as pointed out in the presentation, maybe in those areas that are more logistically challenging, that would be sufficient. But we're probably going to end up raising those questions and needing to at least alert that there are two parallel ways of talking about decentralization at the moment in Myanmar, and raising how these points of tension are important to take into account, rather than to yet, I think it suggests we'll need to dig in, or someone will need to dig in much more specifically into healthcare as a very complex area, to come up with more precise ideas of where this management can be best addressed. That's all I have to say.
Okay, thank you very much,